So very good morning,
He's
everyone.
not ready.
Am I audible?
Yes, yes, you are audible and visible.
So a very good
Please
morning.
carry on.
I'll be talking about facial nerve anatomy and its clinical application. So it's derived from the second brachial arc. So the muscles of the face, the occipitalis, the platysma, stylohyoid, posterior gastric, stapedius, and auricular muscles, which are derived from the second brachial arc, are supplied by the facial nerve. So all congenital oral dysplasia should be evaluated for the presence, morphology, and the course of facial nerve. Now, broadly, we can divide it into the supranuclear portion, a nuclear portion, and the infranuclear portion. So, the upper motor neuron are located in the facial motor area in the precentral cryosphere. The corticobulbar tract descends with the axons, crosses to the opposite side, and synapses with the lower motor neuron located in the pons. Now, the nerve is anteriorly related to the sixth nerve nucleus and posteriorly related to the sixth nerve nucleus and anteriorly related to the vestibulocochlear nerve. This exits the brainstem and enters the facial canal in the temporal bone, and finally exits the cranial cavity through the stylomastoid abdomen to end into its terminal branches. Now, when it is exiting from the brainstem, it has its motor root and its sensory root, which when they enter into the internal auditory meatus, they join as a single nerve. In the facial canal, the narrowest portion is the labyrinthine segment that is most prone to compression in various lesions. Coming to assessing the level of the lesions depending upon the clinical features. Now, the lower motor neuron has a dorsal portion and lateral and ventral portion. The dorsal portion has got bilateral supply, while the lateral portion has just unilateral supply. So the upper motor neuron spares the upper portion of the face, while the lower motor neuron affects the entire side of ipsilateral side of the face. So the common areas affected in upper motor neuron palsies is the cerebral cortex, the internal capsule, and the cerebral peduncle. Hence, any patient who is presenting of forehead needs a neurological evaluation and referral to a neurosurgeon most probably. Coming to the nuclear area, where if the ventral pons is involved, the facial paralysis will be accompanied by affection of the sixth nerve and a contralateral hemorrhage affection of the corticospinal tract. While if the tegmentum is involved, the facial paralysis would be accompanied and the contralateral hemiplegia would be accompanied by the paralysis of the conjugate gaze to the side of the lesion due to affection of the PPR. Another common area where the nerve is exiting from the brainstem is the cerebropontine angle lesions like the caustic neuron. These would be accompanied by all the gamut of features of facial nerve paralysis, along with the eighth nerve involvement presenting as deafness, vertigo, or tinnitus, and or the fifth nerve involvement presenting as ipsilateral sensory loss, which is tested by corneal reflex. So in any such patient, we have to test the lacrimation and the corneal reflex. Now, when it comes to the infranuclear portion, the sensory, motor, or the parasympathetic functions may be involved to various degrees depending on the level of the lesion. So if the part between the internal acoustic meatus and the geniculate ganglion is involved, all the sensory, motor, and parasympathetic portions, the functions will be affected, leading to not just facial paralysis, but affection of salivation and lacrimation. There will be hyperacusis and loss of taste sensation from the anterior two-thirds of the ipsilateral part of the tongue. However, once the greater petrosal nerve is already exited, the lacrimation will be spared and we can test it with Sherman's. Now, when the nerve to stapedius has already escaped, the hyperacusis won't be there, so there will be a facial paralysis along with affection of the salivation and loss of taste sensation. Now, the terminal branch would only produce the motor symptoms, that is the affection of the facial magnetic muscles. Coming to radiology, if we are suspecting a lesion at the cisternal, canalicular, and labyrinthine segments, it's important to mention that the images have to be focused at the internal auditory canals, and a high resolution T2 weighted and contrast enhanced T1 weighted images should be ordered. A temporal bone lesion like a fracture, or a temporal or an affection of the internal ear requires an MRI of the geniculate ganglion along with the temporal bone CT to cover the tympanic and mastoid segment and the stylomastoid foramen. The extracranial segment needs evaluation of the parotid gland area. A common clinical entity we come across is the hemifacial spasm, where the nerve, when it is exiting through the brain stem, is commonly affected by a loop of the posterior inferior cerebral artery or the inferior anterior cerebral artery or the vertebral artery, a combination of these and very rarely a vein. Coming to two important areas, one is the temporal area, where the branches of the temporal nerve lie deep to the superficial temporal fascia. So while performing a brow lift or a facelift, we have to be careful of this area. Similarly, in the lower face, when the branches are running deep to the superficial musculoepineuritic system, they become superficial just medial to the masseter muscle, where we have to be careful. The synkinetic syndromes like Frey's syndrome, where the parasympathetic branches start innervating the sweat glands and the cutaneous tissue, and hence there is sweating and flushing during mastication. Similarly, in crocodile tears, which usually follows Bell's palsy, the salivatory nerves start synkinetic or they are misdirected to the lacrimal gland, and hence during mastication there is lacrimation. So to conclude, applying the anatomy with the clinical history and examination help us identify the probable cause of facial nerve palsy and hence directs our management appropriately. Thank you for your kind attention.